Okay, I think we have a pretty nice quorum. So thanks again for joining us in our third session this week. I think it's my second in a row, or fourth session. I guess we're on the fourth session already. In Cardio's health equity and cardiovascular risk. Let me just quickly go through the introductory slides. Remember to avoid any discussion of personal health information. This is our contact. Please note Andy Christopher's email there, because she will be taking over shortly, we assume, depending on Claire's outlook there in terms of her pregnancy. And this is some information about cardio, and I will be facilitating as usual. And I believe Danette and I are the commentators today. This is our list of our participating sites. And this is what we are going to present today. We have two cases from Fawn and McLean and from Austin. So these are our disclosure statements. And we will begin. So this is a talk that, I can tell you that almost everybody comes to the same place. And as a physician and having been in this area for a long time, yes, I love caring for individual patients and setting the stage and helping them succeed when you can. And that's what doctors do after all. But at a certain point, everybody realizes, gosh, I wish I could help more people. But if our environment was only better, and how can I advocate for a healthier environment? So that's part of what we're going to talk about today. There's a lot of misconceptions about food environments and health equity. And unfortunately, this has become really politicized and in ways that I don't think are productive overall. So I want to start with a thought exercise. So prior to coming to Cleveland, as many of you know, was at the University of Chicago, which is renowned for its Department of Economics and behavioral economics in particular. But let's start with a thought exercise that will give you an idea of how challenging it is to change what people eat and how they value their health. So let's assume that we are all single people, in other words, no dependents, we have no family. I know it's not true, but let's just say that's the situation. And we all make $100,000 a year as a round figure. And I tell you that you have a 2% chance of dying in a car accident in the next 12 months, over the next year. In other words, by October 5th of 2024, 2% chance. Or let's not say it's dying. Let's say it's being severely injured as an alternative, and to make it a little less morbid. And I can lower your risk from 2% to 1%. How much are you willing to pay for that lowering of risk? That's the exercise I want you to consider. Now, I don't want you to blurt out your numbers because they're not going to be meaningful without a lot more context. But let's just think about it for about 30 seconds while I continue speaking. So how much are you willing to pay to lower your risk from 2% to 1%? And then I'm going to ask you some questions about what kinds of people are willing to pay more and what kinds of people are willing to pay less. So senior citizens versus young adults, who's willing to pay more? Well, that one should probably be fairly straightforward. It's young adults who are willing to pay much more. They may pay $10,000 of their $100,000. And it's because they have a much longer life expectancy. And in a sense, they have much more to protect in the long term. If you're 90 years old and someone says, hey, you have a 2% chance of dying in a car accident, do you want to lower it to 1%? And you go, no, I'm not going to be paying more than $50 for that, right? Because, hey, I've lived 90 years. Okay. Who's willing to pay more, men or women? And even that one should probably be fairly obvious to you if you think about it. Women are willing to pay much, much more. In fact, they're willing to pay more for their spouses and their male partners than those male partners are willing to pay for themselves. They would, if you have a husband and wife in the situation, the wife would say, oh, I'll pay $5,000 for him. He goes, don't bother. We can get, something new. Why would we do that? They're not willing to pay anything. And that's a natural one because men are much, much bigger risk takers. Women are much more risk averse. And so the prospect of reducing risk for someone is is attractive to them. How about people with higher levels of education versus lower levels of education? And if you think about it, that's probably pretty significant as well, that people with higher levels of education are willing to pay more. And it's not because they understand risk. Let's say we've made this absolutely clear so everybody's on the same page. They are willing to pay more for to lower their risk. And education is often a proxy for income. Now, I've given everybody the same income in this exercise. So, and what does this really tell us? Well, I mean, being injured in a car accident or dying is a pretty terrible outcome. And it is a health-related outcome in a sense. And it tells us that people who are of higher education and who are of a higher income, generally speaking, have more to protect and therefore are less risk averse when it comes to health risks. And when we think about it, well, if we think about things in that way, we can start to understand why certain drivers of health-related behaviors are important, just purely from this sort of economic standpoint. When you have more to protect, you are less likely to take health risks or to engage in risky health behavior. It doesn't matter what gender you belong to, race or ethnicity. The more money you make, the healthier you are, okay, for a number of reasons. So let's look at how this influences food sources and food environments in a little bit. So the objectives here are to define food desert, which since 2012 has been really called into question as a term that's of value. Describe the role of food deserts in relation to food preferences and food justice as a strategy. So what is a food desert? It's an area where it is difficult to buy fresh, healthy, nutritious food. I think that's pretty well known. The term that I think that is more relevant to our patients and the ones we're trying to help is something called a food swamp. Okay, I don't know of any place in the United States, maybe some rural areas where there is no food available, right? But in many poor communities, it's not the lack of food, it's the type of food that's available. And they live in food swamps. And I just, on the way down here, drove down Lee Road here in Cleveland, and it is full of fast food restaurants. So there are lots of places like that across the country. Food deserts do exist. You can define it in many ways. Neighborhoods in which there is little healthy food available. But pretty conclusively now in the year 2023, the drivers of healthy eating disparities are not the geographic location of healthy food, but rather income and class, which is the point I was trying to make in our thought exercise. So if you build it, they may not come. In fact, it turns out they probably won't. Okay, and the prototype example, and I know I used to do, a lot of you know, I used to do ECHO with the University of Chicago for many, many, many years. The prototypic example was the big, and I don't know if anyone's from Chicago, but the big publicity around building the Whole Foods in Hyde Park, which is near the campus of the University of Chicago. They were going to hire people from the community. It was going to inspire healthy eating. It was going to have a huge impact. And actually, I'll admit, the Whole Foods is thriving down there. But I've been in there many times, and the only people I've seen in there are faculty members and students from the University of Chicago, right? You don't see a lot of local people, and there's lots of reasons for it. It's expensive. It doesn't cater to the dietary preferences of people in the community, etc. You can build supermarkets in poor neighborhoods. Does it have an impact is a big question. Let's move on. So actually, quite convincingly, what happens, and this is a study out of NYU, it's already 4 years old, when you put a new supermarket in there, it meets a political need. You know, people in the community say, we don't have a healthy source of food in this community. Okay, so what happens then? People advocate for a supermarket with fresh produce, for example. And the supermarket chain says, we would love to build a supermarket here, but it's a low-income neighborhood. Our profits are going to be significantly lower here. what can you do to help us out a little bit? So the city of Cleveland, city of Chicago, city of East Cleveland, city of Akron, Toledo will say, oh, well, we'll make it attractive to you. You won't have to pay any property tax for the next 10 years or 20 years. Or we'll throw in a subsidy to help you build the supermarket. And then they'll say, of course, now you're talking. Now that you're talking our language, we'll take that on. So this is what happens in DC. And so they put up their supermarket, and 10 years later, they close it down. And I know that the average subsidy in Washington, D.C. over 10 years, I think, for one of these supermarkets was $2.5 million, which pains me to think how much good $2.5 million could truly do for the health of a community. This is money that they have given away to a private company to put up a supermarket. Does it have any impact? No. What it shows is that people don't change what they eat. They just buy more of the stuff they like to eat at lower prices. And that's probably the exact opposite that we want overall. Now, there are ways to change the food source to influence consumption, but that is not the right way to do it. So what determines what we eat? Well, it's pretty obvious. It's the taste. And number two, it's the taste. And then number three is it's the taste. Okay. And after all of that, it's the cost and it's the convenience. Where does nutrition lie and health lie on the spectrum? Way down the list. And it lies further down the list among our lower income patients, as I said, because they have less to protect. Their health is they have less to protect in relation to their health, whether it's their income, their education, their house, their car, their family, etc. So it's way down the list. Even for people of higher income and higher education, if you don't like the taste of something, you're not going to eat it, period. There's very few people. I've been involved in a lot of these taste testing things with, alternatives, and I can't even tolerate some of the things that has anyone had soy cheese before? I mean, it's just it's brutal. It's just, and you'd have to, and I don't say this lightly. I think to pursue a diet that is based purely on nutrition, you'd have to give up all interest in eating, because some of this stuff is very difficult to eat. Now, I mean, some of you might disagree with me. There are healthy alternatives. Now, the other question is, when are food preferences established? Gosh, I wish it was a little bit later, right? Food preferences are established by the time a child can tell you what he or she wants. It's already ingrained in their mind. So this is a newborn baby reacting to a sweet solution at rest and something that's bitter. Okay, and he's obviously not too fond of the thing that's bitter, sugar, a little smirk. All right, this is a newborn. Okay, a child can tell you what he or she wants, usually around the age of 2.5 or so. And that's when you start to get, those of you who are parents start to get, no, I don't like this, I like this, I want this, I want to grab this, I don't want it, or just, turning your head away. That sort of thing starts around even younger than that. So they've already made up their mind. So this tells us that we have very little time to try to influence food preferences in a significant way. So what determines our body mass index? Okay, when we're talking about younger children, there's the child, there's health status and BMI, there's the type of food, there's the community, there's the parents in the family, and there's genetic predisposition. These all interact together in a way that determines things. If we try to influence only one thing, the neighborhood environment, we're not likely to be successful. So here's a thought exercise I wanted to go through with you. And I know we did this last year as well. Does this look pretty good to people? Show of hands. Anyone? Jim is nodding. Kathleen's nodding. Okay. It looks pretty good, huh? I'm not a big sweet fan, but greasy things, onion rings and stuff, that's my preference. But this looks like a pretty nice dessert table, I think, for most people. And let's say this was catered for some meeting we had. Let's say Cardio decides to have a nice party and we all get this, and this is sitting there. And you decide, hey, this looks great. I'm going to grab one or maybe more of these desserts. Most of us would do that. But would you do it if you knew that the caterer was this woman? I'm going to stop there for a second. Would you touch some of those desserts if you knew that this was who had prepared those? I don't think any of us would. We probably wouldn't hire her again, right? And there's much more to the story. It's pretty horrendous. But why is that? We love these desserts, but we're not going to touch any of this stuff because of who prepared it and what kind of person she is. And it's because we have a sense that sometimes can overcome our preferences, our interest in price, the amount of health that we wish to protect, the convenience of it, the fact that we may not have desserts like that very often. And these are the kinds of things that influences, and it's because of our inherent sense of social justice. So let's talk about food justice as a concept and as a strategy. So food justice originally had something to do with agricultural workers, and obviously in California, with Cesar Chavez, et cetera. For food justice seeks to ensure that the benefits and risks of where, what, and how food is grown, produced, transported, distributed, accessed, and eaten are shared fairly, represents a transformation of the current food system, but it is very, very concerned with eliminating disparities and inequalities. As I said, initially it was about protecting farm workers and paying them a living wage, and so they didn't have to be exposed to pesticides. It's gone way, way beyond that. But it is communities exercising their right to grow, sell, and eat healthy food. Healthy food is fresh, nutritious, affordable, culturally appropriate, and grown locally, etc. But there are three pillars: healthy food for all, sustainable food systems that don't harm the environment, and justice for farm workers. And we can broaden this a little bit. So here are the drivers of consumption. As you can see, I've listed taste as number one overwhelmingly. You know, the most socially conscious, health conscious person is going to give in to something they really like to eat once in a while, and that's okay. Convenience, price are about even, although these days it seems to be convenience more than price. Sustainability very far down the list. I mean, we all think, oh gosh, you know, we can do another thought exercise, but I don't think we need to. But people of higher income and higher education tend to project their own values and their own preferences upon the larger population. You know, it's like, it would be like me telling my patients, oh, make sure it's organic or something like that. Well, that's not going to be a high priority for our patients, for example. So sustainability, environmental protection are pretty far down the list for most people. But we don't know where social justice lies. And this is one of the things that I think presents an interesting opportunity for us, okay? When you say to a community, and I have, and this is in Pittsburgh, which is very similar to Cleveland, your community has lobbied successfully for better schools, for better public transportation, for clean water. Why are you still eating at Burger King? You know, Burger King deliberately targets your children with their marketing. Why are you eating there? And it may not cause a change in behavior. Of course, you know, they'll start by saying, well, taste and convenience and price, those are the things that appeal to me. I have no time, I have to cook, etc. Well, that's all fine. I'm saying this is what they're doing. Do you still want to eat there? And just like the caterer who was abusing her Mexican-American employees, well, maybe they'll have second thoughts about it. I'm not saying this will work, but as a strategy, the other things are not going to work. Right. So, you know, the definition of insanity is doing the same thing over and over again, expecting different results. We can put supermarkets all over the place, but unless people really start to eat healthy food, what will motivate them to do it is to some extent social justice, right? So let's move on here as well. So this is a definition of insanity you guys know about very well. So there are many approaches that we have tried, and I think that the failed approaches, when you keep failing, you have to think of something completely original and new, even if you're unsure that might work, right? And that might not work. So this is often a line that you hear a lot. If only there were healthier food options in poor communities. And I find this very patronizing, right? Okay, if only people had healthier food options, if they would eat healthy food, if I give it to them, they will eat it. The famous experiment from the 1980s now in Burlington, Vermont, which I talk about a lot. Burlington is not a terribly diverse community, but it does have a food bank. And the food bank regularly gets donations of bread from just like a supermarket chain that's left over, plain white bread that costs like $1 a loaf. And for a short period of time, they got donations from an artisan bakery that made, this nut bread and very, very fancy stuff for much, much more. $5 or $6 a loaf is what it sells for. And they put them side by side inside the food bank. And the food bank clients therefore had no convenience, it's free, so no cost differential between the two, right? The only difference was health. And the vast majority of them chose the white bread all the same. Okay, so this idea that if we just provide healthy food, people will eat it, I don't think is a reasonable one. We are projecting our values onto our patients, and that's not right. Why convenience stores don't sell better food? Because, well, if they sold healthy food, people may not buy it. And if it's produce, it'll go bad and they lose money. Here's a nice little example. So in a small corner store in Northeast Washington, Nola Lu, a community outreach worker with the DC Central Kitchen, whirled around the deli case with a clipboard in hand, passing out a recipe for cinnamon pear crisps to anyone who would take it. I pity this poor young woman who had to do this. And then she thrust a card at a man in a blue knit hat who was on his way out. "Are you going to make it for me?" he asked. "I'm not." And she said, "No." He goes, "I'm not much of a baker," he said, and walked out, which I think is pretty typical. Look, it's like, well, you're approaching this guy who probably doesn't cook, probably doesn't eat pears, he's not really interested in this, and you're not going to get anywhere. So let's try something new. Healthy food is not more expensive than unhealthy food. I've done an experiment where I asked, and I don't know how much time we have left. It's $1.50 more per day, but when I was the director of the Pediatric Obesity Center, and I said this a few times, they would send medical students to do research projects with me, which was always challenging because you have to see patients, you've got all this stuff, and I have medical students for clinical care as well. And so I sent this one guy on an experiment. I said, "I want you to go to the supermarket, prepare your lunch, a healthy lunch." This is just for a week, by the way. And to take it to school or to your rotations with you, and then measure how much time and money you spend. And the other thing is, I want you at lunchtime to stand in line at one of the many places. And it's pretty similar, I think, to Case Western, University of Pittsburgh. It's a bit more crowded. And see how long you wait in line to get your lunch, how much money you spend, how long it takes you to eat, etc. And he went to, we gave him the money, by the way, for all this stuff. So he was thrilled about going to Chipotle and Cordova and all these places. It was no contest. It was far, far more time to wait in line, get his lunch, pay for it, eat it, than to prepare a healthy lunch at home. There was no comparison whatsoever. And this is a young single guy. For a family of 4, the difference would be astronomical. You go through a drive-through at McDonald's, I think it would be about $16 or more to feed a family of 4. That is not in the same ballpark, and the time to do that is it's not even close to being competitive. So the idea that healthy food is so expensive should be challenged, I think, at every turn. I simply don't have time to cook and have to deal with a lot of stress. How many of you heard of this? My life is stressful. Yeah, it's true. Lots of people have stressful lives. The amount of time we have to cook has increased significantly over the last 20 or 30 years. It hasn't gone down. And the amount of leisure time that not just women but men have is far more than it used to be a generation or two ago. And here's another social justice slide that makes me angry sometimes. It's why do you get these taste preferences so early in life? You know, it's because of how people are influenced by advertising, especially children. You know, we're going to present some cases today, and I think Fonda has a case of a youngish woman, but Austin's patients are more like mine. They're older, they're middle-aged, and unfortunately, it's very difficult, as we've all experienced, to change what people eat at that point. You can change it for a while, but especially, I think, a patient like Austin's, it's not going to be easy to do. But so advertising of unhealthy foods targets specific communities significantly. And I think if more people knew that, they would start to think about the social justice angle of how to eat healthier. This was a paradigm I came up with sometime. Food justice is a form of empowerment. It's not about what you eat, it's what else you eat, right? So Jim and I run our Fitter Me program, and I asked the same question, you know, I want you to just drink water from now on. And then the response is almost, oh, I drink water. No, just water. And it's sometimes takes a moment for them to think through that. So food justice is recognition that food that is highly processed and high in fat, sugar, and calories has been deliberately marketed to populations which suffer disproportionately from obesity and its consequences. Here's an example. People here in the West, you know, collective West, North America, Western Europe, are generally eating healthier and eating less fast food. So guess where they're marketing it to? They're marketing it in poor countries now. Empowering consumers to make choices not only based on primary drivers, but also on the basis of fair and just marketing practices is the E part. Advocating for healthier food from existing sources and declining food that isn't aligned with one's values. No, thank you. I'm going to not eat that because it's not aligned with my values of social justice. So that's how I think we have to think about it. Recognition, empowerment, advocate, and declining. And these are just ways to do it. Does your snack need to be so high in sugar? No, thank you. Not only is that a poor beverage choice, but I don't like the way the company targets people in my community. I've never heard this from a patient before. He goes, do you drink a lot of soda? Well, no, I don't, because I don't like the taste. But how many people will say, I don't drink soda because I don't like how you know, this is marketed. I see billboards and it's sold all over my community. But when I go to Chagrin Falls or I go to Solon or places like that, I don't see that so much. Well, maybe we should start hearing about that in that sense. Okay, let me stop there then officially.
This is Karen, Dr. Rao. I really enjoyed this discussion, and I really think that just increasing the awareness of people around us as to how the food companies aggressively market to our kids. I think that that can change the way people think about choices in the grocery store. I'm hoping that just increase conversations about that. And then also about taste preferences. I have noticed that people that decrease their sodium intake because of recommendations from their doctor regarding high blood pressure, their taste preferences do change a little bit. I mean, salty foods become, super salty when they get used to less salt. And I think they can do the same thing with sugar. They
have.
And I think just having that conversation with people that, it is possible to kind of change your taste preferences. Right now, you're so used to eating a donut for breakfast. But, if you start changing it, after a while, you may actually find other things you prefer. And, the health boon to that of keeping you out of the doctor's office and having to go on insulin or increase your medications. Think about that. What happens after you eat something is so important. And so I think it is possible to move the needle, but it is going uphill all the way against a lot of marketing, a lot of aggressive.
Yeah. So thanks for sharing that, Karen. So there's many different ways of doing it. Some of you may know this, the amount of sugar in cornflakes decreases, I think 1% per year or something like that in Britain faster. And I think it was Jackson who pointed out, and I'm glad he was able to join us. In Britain, they've lowered sodium ever so slightly so people don't notice it. And they've seen some significant health benefits as a result of it as well. The other experiment I used to try with kids, and I don't do it with the adult Fit or Me patients as it's a different situation, but I say, I want you to drink water for the next 3 months, okay? And then they come back 3 months later and I give them here a glass and I say, they ask me, what's that? I say, it's regular soda. I want you to drink it. And they find it was, oh my God, that's awful. I said, yeah. So there is a transformation that can take place. So it's definitely not a hopeless cause. Okay.
So just as a reminder, we do have our cardio webinar coming up on October 25th. You can visit the cardio website to register or use the QR code linked on this slide. A reminder that you can view all past clinic recordings and current clinic recordings at the cardio website as well. And then next slide. And a couple of reminders, you should have received a post-clinic survey in your inbox. If you didn't, please let me know. There's a couple of issues last week. If you haven't sent us case studies, please do. Or if you want to submit a third, please go ahead and submit. We still have a few weeks that are empty for this session. And then just email me if you have any questions.
Okay. Thank you, everyone. And have a wonderful week. And we'll see you next week. Take care. Bye-bye.
Bye.